morning, and thank you for joining the NeedyMeds special topic webinar, Interstitial Lung Disease in Scleroderma. My name is Carla. I'm the Director of Education and Partnerships at NeedyMeds. And before we get started with today's presentation, I'd like to go over a few tips. You can type any questions you may have into the questions section of your GoToWebinar control panel. Just know we will reserve answering questions until the end. And if we don't have the time to answer your question, we will follow up with you personally via email. I will provide the contact information for NeedyMeds and the Scleroderma Foundation at the end of the presentation. Also, this webinar is being recorded and will be available for viewing on our YouTube channel. And you can find the PowerPoint slide decks in the handout section of your control panel. So with that, let's get started with what is NeedyMeds. What you are looking at is our mission statement, our vision statement, and how we achieve our mission. But simply put, NeedyMeds connects people to programs that will help them afford their healthcare expenses. And we do this free and anonymously through our website, needymeds.org, and our helpline, 1-800-503-6897. And I always like to put up a screenshot of our homepage, because our website is really the face of our organization, and it also gives me a chance to point out just a few resources. If you are interested in locating healthcare cost savings resources, check out the Patient Savings tab. To stay up to date on what's new at NeedyMeds, check out the Advocates tab. This is where you can sign up to receive webinar announcements, sign up for a monthly newsletter, which is now named Vitals, and order brochures and educational materials. In the beginning, I mentioned that this webinar is being recorded, and you will be able to find it on our YouTube channel, which is at the top right of our website with the other social media icons. And you can check out other upcoming webinars and register for them on the calendar of events on the bottom right side of our homepage. And as you saw, a big part of our mission is education, and we define that by educating people about NeedyMeds and the resources we offer, but also by sharing accurate, relevant, and up-to-date information about diagnoses and other healthcare-related resources, which is why we are so thankful to have Angel Soto, a Programs and Services Associate of the Scleroderma Foundation, partnering with us for this webinar, and why we are so pleased to welcome Dr. Fischer, an Associate Professor of Medicine from the University of Colorado, Denver, who will be sharing his expertise with us by presenting today's webinar. I'm going to let Angel give a proper introduction to Dr. Fischer, so I just would like to say a few words about Angel and the Scleroderma Foundation. Angel actually began working with the Scleroderma Foundation in 2016 as a temporary employee. He returns each summer to help organize volunteers for the National Patient Education Conference. And as you can see on your screen, this year's Patient Education Conference is actually coming up in Chicago next month. And you can learn more about that on scleroderma.org/conference. Anyway, after Angel completed his bachelor's in social work, he started working at a nonprofit advocating for adults with developmental disabilities. In 2019, Angel received a permanent position at the Scleroderma Foundation as the Programs and Services Associate. The Scleroderma Foundation has a threefold mission of support, education, and research. They strive to help patients and their families cope with scleroderma through mutual support programs, peer counseling, physicians' referrals, and educational information. They work to promote public awareness and education through patient and health professional seminars, literature, and publicity campaigns. And they also stimulate and support research to improve treatment and ultimately find the cause of and cure for scleroderma and related diseases. The foundation has 20 active chapters and 160 support groups across the country. So without further ado, I'm going to pass the screen and the mic to Angel. So please bear with us while we make that transition, which will hopefully be seamless. And as we do that, I will remind everybody that if you have any questions, you can go ahead and type them into that questions section of your GoToWebinar control panel at any time. Just again, we will reserve answering questions until the end. With that, Angel, go ahead and take it away, and enjoy, everyone.
Good morning, everyone. Thank you for that wonderful introduction of myself and the Scleroderma Foundation. First of all, I just want to thank NeedyMeds and Carla for hosting this webinar. This is a great collaboration and a wonderful way to get, information out to everyone out there. And I also want to thank Dr. Fischer for being here and for presenting this webinar on interstitial lung disease and scleroderma. Dr. Fischer is one of the leading experts in the field and is a member of the Scleroderma Foundation's Medical and Scientific Advisory Board. Dr. Fischer is currently an associate professor of medicine in the Division of Rheumatology and Division of Pulmonary Science and Critical Care Medicine. He's also the director of Autoimmune and Fibrotic Lung Disease Treatment Program at the University of Colorado School of Medicine. He has received several awards for his exceptional practice of medicine, such as in 2007, he received Clinician of the Year from the Department of Medicine at National Jewish Health. In 2014, he received Doctor of the Year from the Scleroderma Foundation and has been continuously recognized as one of the top doctors in the United States. I could go on and on with his awards and accolades, but I'd like to give him a chance to present this webinar for you all. And once again, I would like to thank everyone here for this wonderful collaboration. Thank you.
Thank you very much, Angel, for your kind introduction. Thank you, Carla, as well for your introduction, and sincere thanks to NeedyMeds and to the Scleroderma Foundation for putting on this webinar. It's an honor to speak to you all, and I am very grateful to all of the attendees for spending time with us today to learn more about scleroderma-related interstitial lung disease. It's really my pleasure to speak to you all, and again, I just thank you for your time. Kicking off the talk, just wanting to be clear with regards to terminology as we move forward here. When I say systemic sclerosis, I mean scleroderma. When I say scleroderma, I mean systemic sclerosis for the purposes of today's conversation. Essentially, the classification, I think, unfortunately, can be a bit confusing. And I think there are pitfalls in our terminology. So when we talk about the overall classification of scleroderma, we really want to subset out those without the systemic form, meaning patients that have a focal skin patch, what we usually call morphia, but these can also be described as localized or linear forms of skin thickening. And we want to separate those patients not to belittle their disease by any stretch of the imagination, but just to focus the conversation on the disease that we're really discussing with regards to its impact on organ involvement, and that is systemic sclerosis. So we take the overarching diagnosis or classification of scleroderma, we make a key distinction between those that have the localized or focal areas of skin thickening without systemic disease. And we really don't discuss those for the purposes of today's conversation or with regards to interstitial lung disease. And we focus our conversation on those that have the systemic form. And that's what we either call systemic sclerosis or we call generalized scleroderma. We break that group into three categories, typically those with a little bit of skin involvement, which we call limited cutaneous for skin systemic sclerosis, those that have a lot of skin involvement that we call diffuse cutaneous for skin systemic sclerosis, and those that have the systemic form of the illness but no skin thickening. That's the category of systemic sclerosis, sine Latin for without scleroderma thickened skin. But again, remembering that when we are talking today and moving forward with regards to lung fibrosis or internal organ involvement, we are talking about the systemic form of the disease, formerly called systemic sclerosis. And as I use the term scleroderma, which is a little bit easier to say on a repetitive level than systemic sclerosis, when I say scleroderma, I am referring only to the systemic form of the disease, systemic sclerosis. The term CREST is talked about. It's a helpful mnemonic with regards to some of the manifestations that we see with systemic sclerosis, but sometimes people misunderstand CREST and think of it as perhaps not the full-blown version, not systemic sclerosis. And we want to really dispel that myth. So when we say CREST, we are also referring to systemic sclerosis. And then one more pitfall in terminology is that sometimes people misunderstand that limited systemic sclerosis, limited scleroderma is mild, and diffuse scleroderma, diffuse systemic sclerosis is severe. And that's not really a fair designation, because when we say limited or when we say diffuse, we are really only referring to how much skin involvement a patient has. We are not referring to organ involvement. And so we may see a limited patient who has limited skin involvement, but may have very severe, life-threatening internal organ involvement, such as lung fibrosis. And yet we may see a diffuse patient, meaning they have diffuse skin involvement with very minimal organ involvement. And so limited doesn't really mean mild, and diffuse doesn't necessarily mean severe. It's just connoting and referring to how much skin involvement there is. Hopefully that clarifies a little bit of our terminology. And moving now to lung disease and its terminology, I want to highlight that interstitial lung disease comprises this group of diseases that are characterized by either inflammation or scarring, what we call fibrosis, of the actual lung tissue, which is called the interstitium. Interstitial lung disease is either inflammation or scarring, again, fibrosis, of the actual lung tissue, the interstitium. And we use that term interchangeably with the term lung fibrosis or pulmonary fibrosis. Now, scleroderma-related lung fibrosis is not the same as what you may find with regards to whether it's your internet search or finding information out about a different lung condition, which has a different behavior, a much worse prognosis, and in general, just a worse disease with regards to the lung involvement. And that's a disease called idiopathic pulmonary fibrosis, which means pulmonary fibrosis of no known cause. See, scleroderma patients cannot get idiopathic pulmonary fibrosis because idiopathic pulmonary fibrosis means that the lung fibrosis has arisen without a known cause. But because we know scleroderma is such a prominent cause of lung fibrosis, by definition, if a patient has lung fibrosis and they have scleroderma, we know they cannot have idiopathic pulmonary fibrosis. We know that there's going to be a cause for their lung fibrosis. It may be scleroderma. It most likely is in that patient. It could be some other things like exposures. But just a key message is that scleroderma and idiopathic pulmonary fibrosis are totally different diseases. And what we know about idiopathic pulmonary fibrosis, we can't really extend or borrow to scleroderma lung fibrosis because they behave differently and respond to treatment differently. I've used the term lung fibrosis, I've used the term interstitial lung disease, and these are difficult terms to, I think, get our heads around sometimes. Let's look at some pictures of CAT scans to try to demonstrate that visually for you all. So this is a picture, what we would call a coronal image. The patient is essentially upright. This is a scleroderma patient of mine. And what I'm highlighting here is the lower lung zones that show evidence, as you may be able to see my mouse move here, of interstitial lung disease or lung fibrosis at the bases of the lungs. That picture there is characteristic of what we see in scleroderma patients that have lung fibrosis. The lower lung zones are involved, much more so than the mid and upper lung zones. And the upper and mid lung zones look pretty much like normal lung. To orient you further, this is the spine right down the center. And we can see the liver. We could see the spleen and the stomach. But focusing on the lungs, this is a patient with scarring or inflammation in the lower lung zones that is symmetric, both sides, and I would consider this to be moderate with regards to severity. Maybe about 20 to 30% of their lungs are involved. A more complicated picture, but one that we use a lot to further evaluate our patients, is when we flip the patient onto their back, and this is what we call an axial image. Now the patient's on their back, and we are slicing them, so to speak, with our imaging. So I've taken that picture you just saw before. I've laid the patient back, flat on their back. And now what we're looking at is the base of the lungs and again, highlighting the base of the lungs, have inflammation or scar. It's hard to sometimes distinguish the two by imaging. It may be a combination of inflammation and scar, inflammation and fibrosis. This patient has a bit of a dilated esophagus, something that we see in scleroderma. Here's their liver, here's their heart. But this is when you integrate together now. I've taken, on the next slide, I've taken the coronal images on your left and the axial images on your right, and basically try to subset out the amount of lung involvement. So we take 3 different slices. For example, I have an upper lobe slice where the lung is mostly normal, and you can see that on the coronal images with this horizontal bar correlating to this axial image where most of the lung tissue here is normal. The mid lungs have minimal lung involvement. Just in the periphery of this axial image, you could see just a bit of haze here. And then at the bases, you can see more of the distorted architecture. So scleroderma lung fibrosis is characterized by inflammation or scar, typically in the bases of the lungs, and is usually pretty symmetric. We also may see a dilated esophagus or an enlarged heart, so you can find out other things on a CAT scan. Now, we may see CAT scans, CT scans, which we call high-resolution CT scans, HRCT, in patients with scleroderma that have mild interstitial lung disease. These are a couple of my patients in the top images here that just have a hint of inflammation at the bases of their lungs. Here more in the mid-zones, a little bit of inflammation in the periphery, again, inflammation or a little bit of scar. And then this patient on the bottom has a little bit more lung involvement, a little bit more interstitial lung disease. We may call this more of a moderate degree of ILD, interstitial lung disease. So the CAT scan is going to be a very helpful tool to be able to give us a sense as to whether a patient has interstitial lung disease and how much interstitial lung disease is present. This next image shows us a little bit more severe disease. And again, to orient us all, on this axial image, here is the liver, here are the lung bases, a fair bit of interstitial or lung fibrosis, as we say, ILD, in this patient. A dilated esophagus, pretty characteristic of patients with scleroderma. We know how much esophageal reflux disease and dysmotility, abnormal motility, and the dilated esophagus tips us off to the fact that this is most likely going to be a scleroderma patient when we see cases of lung fibrosis, and this patient has more moderate to severe disease. Now, this is our reality with patients who have systemic sclerosis. We're not going to be surprised when we see interstitial lung disease, lung fibrosis on a scan. About 3/4 of the patients with systemic sclerosis, with scleroderma, have ILD when assessed with a high-resolution CT scan. But most of those patients do not progress. About 1/3 of scleroderma patients with ILD will progress. And so the key is to try to identify those patients that are either at high risk for progression or are progressing. And we know there are some risk factors that we can identify. The SCL70 antibody, the anti-SCL70 antibody, is the strongest predictor for progressive ILD. Skin can be a bit of a predictor for ILD. It's not as strong as the autoantibodies, so we may see more progressive ILD in a diffuse skin thickening patient, but it's not nearly as predictive as the antibodies. We can see more progression in men. In some series, African Americans seem to have more progression. So we know there are some risk factors for progressive disease. But of course, every patient's different, and we always have to individualize the assessment. Now, this is a daunting topic because of what's at risk, right? So we now know, in contrast to the 1970s, in contrast to the 1960s and even the early 1980s, it used to be that kidney involvement, renal crisis, was really the driver of scleroderma-related mortality, of death related to the actual disease. But that's really changed. In the last 30 or 40 years now, what we've seen is that lung disease is the real driver of mortality. And this is a very large series out of Europe, almost 6,000 patients. And what we now know is that most of the scleroderma-related deaths in this disease is interstitial lung disease, about 35%, about a quarter due to pulmonary hypertension, high pressures in the lung, another quarter related to cardiac to heart disease, and much less related to renal crisis. So with a fair degree of trepidation regarding the topic, we recognize that as a provider for scleroderma, and I would imagine as a patient with scleroderma, you got to be relatively lung and heart focused just because of what's at stake. And so assessing for interstitial lung disease, trying to identify if it's there and identifying those that are progressing is really going to be important. Now, the terminology I already told you is tricky, and we talk about scleroderma and thickened skin. But, I think we all recognize this is not a skin disease, right? This is a systemic autoimmune disease. And most scleroderma patients will have lung involvement. I already told you about 3/4 have interstitial lung disease. About 10% have pulmonary hypertension. Now, skin thickening is, of course, an important feature, and in some people it may be the most severe feature, but it isn't as reliable to tell us about organ involvement. Yes, diffuse skin thickening does have a slightly higher risk of progressive ILD, but it's not that strong of a risk, and we just need to look deeper than the skin. The skin tells us about the skin in many cases, not always about the lungs, and I've reminded you about our terminology. We have today a discussion on systemic sclerosis, which we're calling scleroderma. We talk about limited and diffuse skin involvement, but again, these are all systemic autoimmune diseases. You probably have already gotten the sense from me that high resolution, these fine slices on a CT scan, is really the test of choice to know if a scleroderma patient has interstitial lung disease, and we rarely need a biopsy. We usually can just determine this by the actual images. So this is the test of choice to detect if a scleroderma patient has interstitial lung disease. It's an easy test to perform. It's covered by insurances. We can learn about the esophagus. It may even tell us about pulmonary hypertension. And I would just caution us to not stop with a chest X-ray. Chest X-rays are inadequate to determine if a patient with scleroderma has interstitial lung disease. We really need an HRCT scan. 2 separate series just to highlight that. One really small series, 23 scleroderma patients who underwent a CAT scan and a chest X-ray. Well, by the CAT scan method, 91% of those patients had interstitial lung disease, but by chest X-ray, only about 40%. So you miss a lot of interstitial lung disease if you do a chest X-ray alone. A bigger series out of Canada, about 290 scleroderma patients, and 64% had interstitial lung disease by a chest CT, but only 22% of that same cohort by chest X-ray. So again, the high-resolution CT scan will let us know whether a patient has interstitial lung disease. We're not surprised when we find it. We see it in about 3/4 of the patients. But now we got to look at the functional impact. Does it matter? Is the patient progressing? And when we talk about functional impact, we're really talking about lung function testing as an important test here. But it has to be interpreted with caution and within the context of the CT scan, because an abnormal PFT, pulmonary function test, does not mean the patient has interstitial lung disease. Patients with skin thickening can impact their ability to take deep breaths and exhale, the effort, the coaching, the machinery, and there's a wide range of normal on lung function testing. And so what is called normal, such as a forced vital capacity of 85%, may not actually be normal if the patient has been declining. And so if there's a wide range of normal, and they were at 120%, which was normal, and then a year later 110%, and then a year later 90%, and then a year later 85%, yes, they're all normal, but the patient is in fact progressing. One study, just to highlight that sometimes if you rely on lung function tests alone, we will miss the presence of interstitial lung disease. So this was 102 patients with scleroderma, and 64 of them, 63%, had significant lung disease on a CAT scan. Okay, so 64 out of 102, 63% had interstitial lung disease on a CT scan. Let's look at the PFTs in that cohort. Of those patients, of those 64, 63% of them had normal lung function. So they had CT scan evidence of interstitial lung disease, but normal lung function. And a small subset had normal lung function, but even severe disease. So the CT scan is going to be critical to know if a patient has interstitial lung disease. I would caution all of us to not stop the assessment in the absence of symptoms. What do I mean? So a patient who has symptoms of shortness of breath needs evaluation, and they need an extensive evaluation beyond interstitial lung disease, heart disease, anemia, depression. A cough may not be that reliable because cough can be by so many other things, and particularly esophageal reflux disease. But what if my scleroderma patient doesn't tell me that they're short of breath? They're not really short of breath. That doesn't mean I don't look for interstitial lung disease. So the lack of shortness of breath doesn't dissuade us from looking for the presence of interstitial lung disease, because it may be there. And the physical exam may or may not be all that helpful. The doctor may hear crackles, what we call, evidence that there may be scarring at the bases of the lungs. When we hear crackles at the bases of the lungs, we sometimes think about fluid. We do think about lung fibrosis. But just because they don't have crackles, the patient may still have interstitial lung disease. We may have to, again, further assess. And then when we talk about functional limitations, we want to talk about how is the patient impaired? Are they short of breath? What's contributing to that? And we must objectify that by looking at lung function testing, looking at walk testing, and looking at how much disease there is. So even though lung function may not tell us if the patient has lung fibrosis, it can help us understand how severe, how mild, how preserved, or how impaired they are with regards to their function. Same with a walk test. We can learn about their oxygen use, if needing any supplemental oxygen, and looking at the CAT scan will tell us a lot more about how much lung disease there is. Now, we're only going to want to treat those patients with lung fibrosis when it is associated with impairment, when it's considered to be clinically significant, when there's high risk of progression perhaps, or certainly when there is evidence of progression. So about 3/4 will get interstitial lung disease, about 1/3 will progress. And we really want to reserve those, the treatments to those that are progressing, or those that have high enough risk factors for progression that we may want to be a little bit more proactive. But that being said, many scleroderma patients who have interstitial lung disease, it's mild. We see it on imaging. It's not causing symptoms. We don't see any lung function decline. We're following these patients over time. It's not progressing. And in those cases, we don't want to institute therapy because we're giving drugs that have risks, and they may not be needed. And so we want to reserve treatment to those that are showing signs of progression. And I want to spend the next 15, 20 minutes really talking about what's been, I think, learned about how we approach treatment in patients that have progressive lung fibrosis with their scleroderma. And it basically, at this point, comes down to 2 drugs. It comes down to mycophenolate mofetil, called Cellcept, and it comes down to cyclophosphamide, also called Cytoxan. Those are really the anchors. Those are what we know the most about, and those are the primary treatments for this disease when it comes to medications. Rituximab, we don't have enough data to really be able to recommend that treatment in this disease for lung fibrosis. Same with tocilizumab, Actemra. We just don't know whether the drug makes any sense to treat lung fibrosis. We don't have good studies to help us there. Stem cell transplant, we don't know. We think that the stem cell transplant may help the lung fibrosis, but it hasn't been definitively studied. And so we can't really say that that's a proven therapy for interstitial lung disease and scleroderma. We use that one more for really severe diffuse skin involvement. I think what we've learned is that some patients with lung fibrosis who do get a stem cell transplant may show some benefit in that regard. Azathioprine or Imuran, no real data to help us determine whether or not that's an effective drug in this disease. And so really it comes down to mycophenolate, Cellcept, and cyclophosphamide. And corticosteroids like prednisone are a mixed bag. Scleroderma tends not to be all that responsive to prednisone in general. There are concerns in patients that have diffuse skin involvement that prednisone may be associated with a higher risk of kidney crisis. And so there's always some degree of caution about using steroids in scleroderma. When we use it in a chronic stable state, we may try to keep the dose under 15, under 20 milligrams per day, which may be less risky on the kidneys. But sometimes there are very dire situations where the patient has an exacerbation, an acute worsening, a hospitalization, and there are no choice. You don't have a choice. You have to kind of try to prioritize the scenario, and the patient may in fact need high-dose steroids. Now, in terms of non-drug therapy, things that don't get as much attention, we talk about mycophenolate, we talk about cyclophosphamide, but these are important modalities to really think hard about and talk to your doctors, talk to your providers about. Pulmonary rehabilitation. Am I using supplemental oxygen correctly? Is the reflux disease and the aspiration being addressed? Have I gotten my appropriate vaccinations, and am I being taken care of in general, right? Not just my lungs, but how about the overall patient, and including mental health? And I pulled this picture off of the internet, which I think does demonstrate, so I should thank the Cardiac Wellness Institute, I guess. But if you look at this cycle, I think as a provider we see this. Patients have a hard time breathing. They become inactive. They get deconditioned, and they get disabled. And it's a cycle that's, I would argue, is a vicious cycle that we want to do our best to try to counter. And so as we see patients that are impaired with respiratory problems, we want to fight that desire, so to speak, to be inactive and push, so to speak, to pulmonary rehab, to activity, to try to avoid physical deconditioning. A few studies to walk through. I'm going to walk through the Scleroderma Lung Study I, just broad conclusions, the Scleroderma Lung Study II, broad conclusions, and then show you some new information that you may not have seen related to antifibrotic therapy in this patient population in scleroderma lung fibrosis. So the Scleroderma Lung Study I, which was published already 13 years ago, believe it or not, was a really pivotal trial. And this compared patients with scleroderma lung fibrosis with two treatment arms. One was a placebo. The other was Cytoxan, oral cyclophosphamide. And what we saw in this 12-month trial, that those that got cyclophosphamide, Cytoxan, compared to placebo, they had a modest improvement in their lung function at 12 months, a little bit of a bump. Improvement in their lung function, improvement in quality of life. The CT scan looked a little better. The skin thickening was a little bit less. So improvement in skin in the CT scan, patients felt a bit better, some improvement in lung function. But this is a 12-month study, and when we looked at the results at 24 months, all the results were gone. All the effects were gone, meaning what we learned, Cytoxan works, it works a bit, patients feel a bit better, skin softens a bit, CAT scan looks a little bit better, but if you stop after 1 year, you get nothing, meaning this is a longer-term treatment. And that's where Scleroderma Lung Study II played out, whereby now we're looking at a longer-term treatment option. Cytoxan for a year versus Cellcept, mycophenolate, for 2 years. And what we saw were similar effects across both drugs, mycophenolate and cyclophosphamide, both helping skin, quality of life, fibrosis on the CT scan, a little bit of improvement in lung function, but mycophenolate was tolerated better, safer, and a much more suitable longer-term option. So now what we'll often do, we can either go with mycophenolate and go longer term. We may go cyclophosphamide up front, switch after 6 months, switch after a year, but then after that we stick with treatment because we know the effects wear off, and we continue for longer-term therapy with mycophenolate mofetil. And so what have we learned in general from these two pivotal trials? Well, we know that now we're in an era where we can conduct successful scleroderma lung fibrosis trials. That's a big deal because that can then extend to other therapeutic options, which I'll show you in a few minutes. We know that both cyclophosphamide and mycophenolate are effective. They're not that great, though. They don't blow the disease, so to speak, out of the water, but they can have some positive effects on lung function, on imaging, skin thickening, quality of life. We know that mycophenolate is far safer, far better tolerated, and is a suitable longer-term option. We know that cyclophosphamide is a good therapy, typically can't really go beyond 1 year. And if you stop after 1 year of cyclophosphamide, you're going to lose ground. And so we may go with cyclophosphamide for 1 year, but then we know we have to transition beyond that to continuous therapy, usually with mycophenolate. And we definitely need more effective therapies. And I've already told you about the other drugs that some of our patients are on. We try them, but I have to be candid to say that we just don't have the studies to back up any specific recommendations with regards to using these drugs for scleroderma lung fibrosis. Now, the landscape is changing a bit. I told you at the outset that scleroderma lung fibrosis is not idiopathic pulmonary fibrosis, and it's not. But we have learned that for that disease, idiopathic pulmonary fibrosis, there are 2 anti-fibrosis drugs that can slow lung function decline. There's nintedanib, and then there's pirfenidone. Nintedanib has been shown. Nintedanib is Ofev, and pirfenidone is Esbriet. Those are their trade names. But what these drugs have been shown to do in a different lung fibrosis condition called IPF, they can slow lung function decline. So the current approach to treating patients with IPF has changed in the last 5 years, whereby patients with IPF can get pirfenidone and nintedanib. Scleroderma lung fibrosis patients are being treated, as I told you, with mycophenolate and cyclophosphamide. Those are immunosuppressive drugs. But we wonder, what about extending those antifibrotic drugs that work for a different lung fibrosis condition to this disease? So there are studies underway, and one which I'll show you with regards to results is the Census trial. But this was an important phase 2 study, an earlier study with regards to pirfenidone. So the Lotus trial didn't look at efficacy really. This was just testing the waters with regards to, can we use an antifibrotic drug called pirfenidone, Esbriet? Can we use that drug in scleroderma patients? And one of the concerns with Esbriet, with pirfenidone, is that it causes a lot of nausea, a lot of upset stomach symptoms, and certainly scleroderma patients are already experiencing many of those symptoms. Is this drug going to be tolerable? And so this study was 60 scleroderma patients with interstitial lung disease, and they got pirfenidone for 4 months. A lot of them were also on mycophenolate, and they showed that pirfenidone was tolerable in this group of patients, giving, I think, support that, hey, we should study pirfenidone further in this patient population. I think reassuring to know antifibrotics can be potentially tried in this group of patients. This is a paper that's really hot off the press. I was involved in the Lotus study as one of the investigators, and I was involved in the scleroderma interstitial lung disease study for nintedanib, as well as a steering committee member for both the Lotus trial, and a steering committee member as well for this large trial. And this is a landmark trial that I think we'll be hearing lots and lots about over the coming years. This is just published in the New England Journal of Medicine, and now just being reported across numerous congresses worldwide. The first time this was presented was at the American Thoracic Society in May, just last month. So this is a huge trial with regards to numbers of patients, almost 600 patients. And in this trial, 288 patients received this antifibrotic drug nintedanib, compared to 288 getting a placebo. And the primary measure to look for efficacy was the forced vital capacity at 52 weeks. So half the patients come in, get a nintedanib, half get a placebo. What else did we do for including patients here? They had to be over 18. They had to have a scleroderma diagnosis. They had to have a diagnosis of less than 7 years duration. They needed to have interstitial lung disease by chest CT. And they needed to have enough ILD by CT scan, more than 10% of their lungs involved. They needed to have a lung function of greater than 40%. So these are patients who have moderate, in some cases moderate severe to severe disease, but not too critical in terms of their overall disease status. And their diffusing capacity had to be as well in that moderate to severe category. They could not have significant liver disease. They couldn't have bleeding risks. They couldn't have heart-related disease such as unstable cardiac disease or a recent heart attack. They couldn't have clotting events within the 12 months, and that has to do with some of the safety concerns related to nintedanib and clot risk and heart disease and liver toxicity. And they could not have significant scleroderma renal involvement. They were allowed to be on prednisone at less than 10 milligrams or equal to 10 milligrams a day. And they could be on background mycophenolate. They could be on background methotrexate as long as they were on stable doses. So some of these patients, and you'll see many, were on background mycophenolate. And the primary outcome measure in this trial was what was the forced vital capacity doing over a year's time? What did the rate of decline in lung function look like when assessed over a 52-week period? And then secondary measures were change in skin scoring, the modified Rodnan skin score. Did the skin get impacted? And also did the symptoms of shortness of breath or quality of life get impacted? This is a busy slide, and really what I just want to show you is the monumental task of this really incredible trial. 819 scleroderma patients worldwide were screened. 580 were randomized, and 576 were ultimately treated. And in terms of who completed all the visits, 264 in the nintedanib arm, 275 in the placebo arm. And this is just a monumental undertaking, and just really can't be understated how impressive of an effort this was in a global trial to get so many scleroderma lung fibrosis patients into this trial. To put it in perspective, in the Scleroderma Lung studies that I showed you, you're looking at about 150, 180 patients total. Here you're 580 patients being randomized, almost 600 patients. What did the patients look like? Well, their average age was in the mid-50s. We did see a female predominance in both arms, 77 versus 74%. Overall, predominantly a white patient population. Very smaller numbers with regards to African American populations. So we have to be careful when we're looking at these data, to wonder, well, can we really extend across? We believe we can extend across ethnic groups and races, but we just have to be aware of what the patient population really looked like. Fair number of Asians, as you saw as well. About half with limited, about half with diffuse skin thickening, so pretty equal distribution there. Again, we talked about getting patients in within 7 years. Average age was about 3.5 years of disease duration. And then in terms of how many were on background mycophenolate, about half of the trial were on background mycophenolate mofetil. How about how much lung involvement? Well, about 20% or so disease extent. So pretty moderate with regards to their lung involvement in terms of severity, and some impairment in their lung function. So impaired lung function, moderate disease extent. How did the patients do? So this is the primary endpoint. And this is critical because this is really the first trial that we've seen of this magnitude to show a positive outcome, meaning a favorable result. This study showed that patients who were treated with nintedanib versus placebo, those with nintedanib lost less lung function, meaning their lung function decline was less than placebo. So those with the placebo got worse and lost more lung function over the course of a year. There was a 44% relative reduction. So if the placebo arm lost in milliliters 93 milliliters per year without nintedanib, those with nintedanib, they did lose lung function, but they only lost 52 milliliters per year, and that difference was 44%, and that was statistically significant. So those with nintedanib treatment lost less lung function than those with placebo. Now, if we take this and partner this now and pair it up with how does that compare to what we learned about IPF, idiopathic pulmonary fibrosis, and what got that drug approved by the Food and Drug Administration in this country and other regulatory agencies around the world, in IPF, patients get worse quicker. So placebo patients in IPF, they lose not the 93 mLs that scleroderma lung fibrosis patients lose. They lose more than double that, 224 mLs per year. And those that got nintedanib, had a 49% relative reduction. They only lost 114. Well, scleroderma patients, lung fibrosis progresses slower in that group, and so 93 mLs per year was the placebo arm. But again, the same relative risk reduction that we saw in idiopathic pulmonary fibrosis, we are seeing in scleroderma lung fibrosis. And if you look at this by graph, in terms of longitudinal separation of the curves, so this is the nintedanib arm at time 0 going out to 52 weeks, and you can see that their lung function is declining. They are showing a decline, but it's not as steep of a drop. It is not as significant of a drop as to those not getting placebo. So the primary outcome in this trial was, how does nintedanib impact lung function? And what we can say is that patients that got nintedanib compared to placebo had less loss of lung function. Now, how does mycophenolate do with this? Because patients, about half of them are also on mycophenolate. So this is 4 groups in this study, because there's a true placebo on the far right. Patients who are not taking mycophenolate and patients who are not getting nintedanib, so they're placebo across the board, they lose 119 mLs per year. How about those patients who are just on nintedanib? So they're not taking mycophenolate. They're not taking mycophenolate, they're getting nintedanib, they lose 64 ml per year, a relative reduction of 46%. Now, how about those patients who are just taking mycophenolate, not taking nintedanib? Well, they lose 67 mLs per year. And how about those patients that are getting both mycophenolate and nintedanib? They lose 40 ml per year. That's the group that did the best, the patients that were on both mycophenolate and nintedanib. Now, nintedanib was effective either way, and it was associated with a relative reduction in both arms. But again, the group that did the worst and lost the most lung function was the patients that were on neither nintedanib or mycophenolate, and the patients that did the best were on both nintedanib and mycophenolate. That group lost the least amount of lung function over the year. I told you a few slides back now that they also looked at the skin and quality of life. Unfortunately, in this trial, those results were not at all impacted by this drug. So the patients who were on nintedanib had no beneficial effects with regards to their skin. There was no difference whatsoever in skin involvement or skin effect, whether the patients were on placebo or on nintedanib. I told you about quality of life. They looked at the St. George's Respiratory Questionnaire. We looked at that. It didn't make a difference. Patients did not feel any less breathless. It did not impact their symptoms. Being on nintedanib versus placebo did not impact symptoms. How about a different shortness of breath score, the FACIT? No difference there either. A p-value that was not significant. So whether the patients were on placebo or nintedanib, it did not impact their symptoms. And their overall health assessment questionnaire, what we call the HAQ-DI health assessment questionnaire, no difference. So whether patients got nintedanib or placebo, no difference, p-value 0.35. So really ignore the bar graphs that look like there's a separation. This is not statistically significant. There was no difference. In terms of adverse events, so if you looked at those that got nintedanib, 16% had an adverse event that led them to stop the drug compared to 9% with placebo. So more patients with nintedanib had to stop the drug due to a significant adverse effect. And in terms of the severe adverse effects, well, there were more of those in the nintedanib arm. 18% had a severe adverse effect compared to 12.5% in placebo. And so there are more side effects with regards to needing to stop the drug and more side effects that were serious in those that were on nintedanib. And if you wanted to see what the most common adverse effects were, what could we expect? Really not a surprise, because we know from the idiopathic pulmonary fibrosis trials from IPF, diarrhea predominates. 76% of patients who were on nintedanib reported diarrhea compared to only 32% on placebo. More nausea, 32% compared to 13.5%. More vomiting, 25% versus 10.4%. So the side effects that stand out are really gastrointestinal. A lot of words on this slide. I'm just going to summarize the safety tolerability in a few words of my own here. Essentially, what this trial showed was that similar to IPF, we saw a very similar safety tolerability profile. A lot of GI manifestations, gastrointestinal as the limiting factor, diarrhea, vomiting, upset stomach, nausea. More patients with nintedanib had to stop the trial because of these adverse effects. But about 80% or more were able to stay on nintedanib for the full duration of the trial. In terms of the efficacy, does the drug work? Well, the primary outcome was favorable. Again, being on nintedanib compared to placebo was associated with loss of lung function at a slower rate, less lung function decline compared to placebo. And being on the combination of mycophenolate and nintedanib had the most favorable effects. That being said, did not impact the skin, did not impact shortness of breath, did not impact quality of life. There'll be another study of antifibrotics, and that's the Scleroderma Lung Study III. Correct this slide, it's actively enrolling. It's not enrolling soon, it is actively enrolling. And these are going to be, this is a different trial. This is going to be allowing background mycophenolate in everybody. So all the patients in the Scleroderma Lung Study III are going to go on background mycophenolate, then half are going to go on pirfenidone, and half are going to go on placebo. It's an 18-month trial, and similar to what I just showed you with census, lung function is the primary outcome measure, and then important secondary outcome measures like skin, quality of life, and CT scan fibrosis. I just want to highlight that when we see patients with scleroderma interstitial lung disease, we need to follow them longitudinally over time, assessing symptoms, their exam. We want to see if they're developing other features like GERD, or as we call it, reflux disease or pulmonary hypertension, and we'll follow their lung function and their imaging. So when we make treatment decisions, right, we're going to need to follow the patients, particularly with lung function, to see how we're doing. Are we winning? Are we losing ground? Are we gaining ground? And I kind of beat up lung function tests about a half hour ago now when I talked about how they're not that helpful to diagnose interstitial lung disease, but just recognize they're really important when we follow our patients because we want to follow their lung function over time. And what we'll do is we'll put like a chart together almost in our patient charts, whereby we're looking at their lung function at time 0, at 3 months, 6 months, 12 months, and so we'll trend these out to see how our patients are doing. Are they tolerating their medications? Are they stable with lung function? And quite often, if we can prevent decline, stability equals success. I just want to round out the talk on just a couple of slides related to final thoughts here, and that's you can't really talk about scleroderma lung fibrosis and its treatment without at least bringing up lung transplantation, and this would be reserved for those patients that progress despite our medication therapies, despite mycophenolate, despite cyclophosphamide. Most scleroderma IL patients have a hard time getting a lung transplant because we worry about their esophageal reflux disease. But that being said, if we can get carefully selected patients with scleroderma lung fibrosis, we can see that those patients may do as well long term as patients with other forms of lung fibrosis. And so we can really impact favorably on 1, 3, and 5-year survival curves for patients who otherwise are facing dire consequences from their lung fibrosis. This was a whirlwind 45 minutes for many of you, covered a lot of material, and I want to leave you with 6 messages with these next 2 slides. Number 1, lung fibrosis, interstitial lung disease. It's a large group of diseases, and we're talking about inflammation or scarring in the lung. I've highlighted bullet 2. About 3/4 of scleroderma patients have lung fibrosis by a CT scan. About 30% have progressive interstitial lung disease. We know there are some risk factors like SCL70 antibody positivity. We want to reserve treatment for those with clinically significant progressive lung disease. We know that the high-resolution CT scan is the test of choice to know if a patient has interstitial lung disease, and we rarely need a lung biopsy in scleroderma lung fibrosis. What do we know about treatment? Cyclophosphamide and mycophenolate are the proven therapies for scleroderma interstitial lung disease, but we know they only have modest benefit. They do impact skin favorably. They can impact the CT scan. They can impact quality of life. We need better therapies, though. That being said, if we can stabilize patients with this disease when they're progressing, we'll consider that for the time being a success. The Census trial, that's nintedanib in this patient population. Huge trial, almost 600 patients. What did we learn? Treatment with nintedanib slows the decline in lung function compared to placebo to a modest degree, and it can be used alongside mycophenolate, but not effective for skin and does not impact quality of life, did not impact the way patients felt. It is not available yet, and it may be available pending regulatory review. The Food and Drug Administration is reviewing this trial and discussing at high levels whether or not to approve this therapy for scleroderma interstitial lung disease. Until that time, it is not indicated and is not available for scleroderma lung fibrosis patients, and that may change. And the last point is that although lung function tests are not adequate to diagnose lung fibrosis, they're going to be really important for the longitudinal assessment and care of these patients, following our patients to see how they're doing. I think it's an exciting era with regards to the conduct of clinical trials. We're seeing, for the first time, positive results in a disease state where we really didn't have any with regards to lung fibrosis. And now we're in an era of cyclophosphamide, of mycophenolate, and perhaps even of nintedanib. And we'll see whether pirfenidone and the Scleroderma Lung Study III shows a positive result as well. And there are numerous other trials and drugs being looked at in this arena. So I'm hopeful that down the road we won't be talking about stability equals success, but perhaps even significant improvement. Thank you all very much, and I know I've gone over my time a bit here. I'm just very grateful for all your attendance and participation in this webinar. Thank you again to NeedyMeds, and thank you to the Scleroderma Foundation.
Dr. Fischer, thank you so much for the thorough presentation. We are so pleased. We were honored to have you as our guest and so pleased you generously shared your expertise with the NeedyMeds community today. I do see a lot of questions coming in, and again, you can type them into the question section of your control panel. And as those are coming in, I do want to remind everybody that NeedyMeds is here for a source of support. On your screen is our most popular and cost-effective healthcare cost savings resources that we do hope you take advantage of. If you want to learn more, you can sign up for one of our upcoming monthly overview webinars, and you can find those on the calendar of events on the bottom right hand of the NeedyMeds homepage, which I pointed out in the beginning of the webinar. So let's get to those questions. And as we do, I'm going to go ahead and leave up the contact information for the Scleroderma Foundation and NeedyMeds. And I will remind everybody that time is limited, certainly for the question segment. And if we don't get the chance to answer your question, we will follow up with you. So Dr. Fischer, one of the questions coming in is, what is the average time frame of this disease as a result of scleroderma, and what are some of the initial symptoms?
Some of the initial symptoms can be pretty subtle and vague and not that specific. So lung fibrosis can present with just fatigue, can present with cough, can present with shortness of breath with activity. Sometimes those symptoms are present, and there's so many things that can cause fatigue and feeling short of breath that you can't really rely on them. And so they're not such specific with regards to symptoms. And as I mentioned, sometimes lack of symptoms, is falsely reassuring. Patients may not feel that much, but may still have early interstitial lung disease. In terms of timing, so sometimes lung fibrosis is present from the outset. The patient has Raynaud's phenomenon for several years. Ultimately, a little bit of skin or puffy hands or a blood test or reflux disease, something tips off another feature of the disease. A CAT scan is obtained, and there's already interstitial lung disease. Sometimes interstitial lung disease is there really from the get-go. Raynaud's phenomenon and interstitial lung disease right at the outset. Sometimes patients have had Raynaud's phenomenon for years and years and years, and then interstitial lung disease is seen. What we do know in terms of progression, it tends to be more progressive early in the disease course, first 5 to 7 years, which is why most clinical trials that are looking for a drug to treat lung fibrosis will want patients who have had early disease to see if we can pick up a signal in those patients, meaning they're at risk for progression. It's the first 5 to 7 years, and that's where we'll see more progressive disease.
Thank you so much, and thank you to our audience member for inquiring about that. Another question we have coming in, does the fibrosing, and forgive me if I'm pronouncing that incorrectly, always occur starting from the lower lung? And if so, is there a reason for this?
It tends to be lower lung predominant. I wouldn't use the word always because there are exceptions to the rule. But in general, it is lower lung predominant, and we don't really know why. The autoimmune patients in general tend to have lower lung zone predominant fibrosis. Upper lung zone predominant fibrosis is very atypical in scleroderma.
Thank you. And are lung transplants suggested at different times for PAH and ILD?
Yes, for PAH, there are better therapies than we have for lung fibrosis, and there are fewer and fewer patients needing lung transplant for pulmonary hypertension because the drugs are more effective. If a patient has progressive pulmonary hypertension, though, and ultimately they are progressing despite all the novel therapies that are available, patients may undergo transplant evaluation for progressive pulmonary hypertension. Lung fibrosis, I did highlight that we have a few drugs that look to slow the disease down, modest improvement, but certainly not blowing the disease out of the water, not showing the same degree of efficacy as we are with pulmonary hypertension drugs. And so more patients with lung fibrosis are progressing, and those patients, if progressing and individualized by scenario, we don't want to forget that lung transplantation can be an option.
Thank you again. And we're going to wrap up with one final question. And Dr. Fischer, although this might be for you, it might also be for Angel at the Scleroderma Foundation. The question is, where do I go for clinical trials if I have lung involvement?
Well, I'll step in first and let Angel after. First of all, there's a website that patients can go to called clinicaltrials.gov, G-O-V, clinicaltrials.gov, that lists really all the clinical trials going on in the United States. And you can search by scleroderma, and you can search by interstitial lung disease. The other thing is the Scleroderma Foundation, Angel can speak to this, has centers of excellence that focus on scleroderma care and research and education, and has a listing of all those centers and their available clinical trials.
Very helpful.
Hello?
Hi, Angel. Did you have something you'd like to add as well?
Yes, actually, that was perfect, Dr. Fischer, and wonderful presentation, by the way. I learned quite a bit. But we have scleroderma centers across the United States. We have 40 plus, and they do list their trials. If you have a hard time reaching those, you can get to them via our website or give us a call here or with that information that you see right there on the screen, and we can definitely help connect you to trials that are close to your area. Thank you.
Thank you for adding that. And as I had mentioned, there are still a lot of questions coming in, but we are out of time. So just a reminder again that if we didn't get the chance to answer your specific question, we will follow up with you via email. But as Angel just said, you can certainly reach out to the Scleroderma Foundation. It's scleroderma.org or 1-800-722-HOPE, which is 4673. With that, a big thank you to Angel and the Scleroderma Foundation for this collaboration, and of course to Dr. Fischer. Again, we were honored for him taking the time to share his expertise with us. And thanks to our audience for taking time out of your day to join us, and to join us. And we do hope you stay in touch. Thanks, everyone, and take care.